Well, Nunkri Nungi, everyone. G'day from Ngarrindjeri country. My name's Professor Paul Worley. I'm here in Pomeroy or Murray Bridge. And you're here as part of the Riverland Academy of Clinical Excellence Grand Rounds, an opportunity for our health service and our academy to learn from the best around the world, so that the care that we provide, the research that we do, and the training that underpins all of that can be the absolute best for our communities. We have a real treasure today. Professor Akiteru Takamura is a professor of family medicine at Toyama University in Japan, and expert on rural health in Japan, and has the benefit of having lived and worked for a time in the Riverland whilst he was studying his Masters of Education. So we have the opportunity to learn from the experience of rural healthcare in Japan, what messages we can have from here, and how we potentially might be able to work together to improve the health of the people who live in both our areas. Professor Takamura, welcome. Welcome to the Riverland Academy of Clinical Excellence, and we look forward to hearing your description of rural healthcare in Japan, and then the opportunity for some questions afterwards. Professor Takamura.
Yeah, thank you very much for a wonderful introduction about myself. So, before the beginning of my presentation, actually, so my English is not so good. So if you have some trouble to understand what I'm saying, don't hesitate to tell me and ask me to talk again. So today, so I'm going to talk about rural healthcare in Japan. Before the presentation, I'm going to introduce myself briefly. I'm Akiteru Takamura. As a pronunciation, Akiteru Takamura is very similar to Japanese pronunciation. I graduated from National Toyama Medical Pharmaceutical University in 1998. And so I'm now 51 years old. And 2008 and 2007 and 8, I studied a master's degree at the Flinders University. And then I worked for Flinders Rural Clinical School 1 year with Paul Worley. And after coming back to Japan, I got a doctor's degree, and then went around developing countries like Laos and Tajikistan and Vietnam and Mongolia to do some community-based medical education things. So my research field is community-based medical education. I published some papers. So today, I'm going to talk about healthcare in Japan. At first, I'm talking overview of basic healthcare system in Japan. So in Japan, almost all citizens join the Medicare cover. And normally, that fee is withholding from our salaries. It depends on the amount of the incomes. And normally, if you go to the hospital or clinic, we have to pay some, even a public hospital.
Yes? I'm going to interrupt you. We can't see any slides.
Oh, really? Sorry.
That's right.
So I'm gonna. Oh my goodness. Yeah. Is that okay?
Perfect. Perfect. Well done. Your descriptions were beautiful, but Through the slides will help.
Yeah, thank you very much. Yeah, so my name is Akiteru Takamura. As in a Japanese pronunciation, like Akiteru Takamura is very similar to Japanese pronunciation. And then, so overview of basic healthcare system in Japan. Almost all citizens are joining Medicare, and that budget is, of course, 70% of the budget is from government, and normally 30% we have to pay in a hospital counter when you are going to a hospital. Approximately, we have to pay 10 Australian dollars for consultation, three Australian dollars for prescription fee, or such kind of amount of the money we have to pay still in a hospital counter. Even that hospital is a public hospital or a private hospital, still same consultation fee, regardless of the doctor's specialty as well. So we normally don't have the system of the like a GP system. So the patient can go to any hospitals in any department to see a specialist. So of course we have to pay some, but the government set the maximum payment. It's almost 3,000 Australian dollars per month. So if above, so we don't need to pay more. But recently, maybe 5 or 6 years ago, the government introduced the new system, which is if no referral letter, we have to pay more at the big hospitals, like over 300 beds or such kind of the hospital. That is an overview of a basic healthcare system in Japan. And then, so the problem is definition of medically rural. I have no idea about the definition of the medically rural in Australia. Paul, do you explain that briefly the medically rural in Australia?
Certainly. So we have regional, rural, and remote in Australia, and it is defined through a system called the modified Monash model, and it essentially is defined by distance from large urban centres, and the further away you are from large urban centres and the smaller your population, you move from regional towns of 50,000 or more to rural towns of 15,000 or 5,000, and remote being the smaller towns, mainly concentrated around the centre of the continent. And medical workforce follows that same gradient. More in less in rural, less in remote.
Yeah, thank you very much. So maybe the definition of medically rural is different between Japan and Australia. As you know, Japan is very small country and also very big population we have. So a bit different. So in a Ministry of Health said like a no medical practitioners district. So this is a definition of the government. Yes, many definition things is in here, but normally it takes more than 1 hour by car to get to the closest medical facilities. That is medically rural. The definition in Japan is. So I don't know how do you think about this is rural or still urban or such kind of things? But fortunately, the Japan is very small country, so it is easier for us to get to the city area or closest medical facilities. So this is the number of the medically rural area in each prefecture. So in Japan, we have 47 prefectures, and each prefecture has their medically rural areas. So this is the graph. It's some of the letters is Japanese, so I'm so sorry to. It's difficult to understand for you. But the Hokkaido area, which is North Island, like very blue things, has the biggest island in Japan. So they have lots of medically rural areas. And Osaka is one of the biggest biggest prefecture in Japan. And Kanagawa, Chiba, Saitama, it's surrounding the Tokyo area. They have no rural areas. But very interestingly, Tokyo has rural area because around here is a very south of the Tokyo area. There are many small islands. So this is joining Tokyo prefecture. So they have remote rural areas. So this is a map of the rural areas in Japan. And history. The 1970s, Japan has a rapid economic growth after World War II. So like a dramatic increase in the working age populations. And at that time, of course, we have a big population even in a rural area. So the local government tried to construct medium-sized, heavily equipped hospital everywhere. Do you know that how many CTs or MRIs in Japan? So the population of Japan is just only 1% to or 2% of the whole world, but 30% or 40% of the CT or MRI is in Japan. So that shows, and after World War, the Japanese government tried to construct a medium-sized but heavily equipped hospital even in a rural area. But 1990s economic bubble burst and start declining in a birth rate, and young generations moved to urban areas because of the less job in rural areas. And after 2000, accelerated aging of the society. Decline of the primary industry like pharmacy, farming things, or like how can I say, wood industry in a mountain area. Such kind of things are declining and facing financial difficulties in rural areas because of the decreasing population. Their tax income is also decreasing and less of the workforce. That kind of things is happening these 30 or 40 years. This is a population trend of Japan. And here is 2024. So our population is start going down. And even especially in a rural area, the aged population rate is recently over 50%. And I have to talk about another history of the medical education. So Japan introduced originally German-style medical education in 18th century or 19th century, which is research based and specialty based, means no family physician or general practitioner. And as I said, hospital-based practice, even in rural areas. So even now, our medicine, our medical care system is specialist-based. Even in a community, there are many specialty clinic, and but as I showed our history, now the number of the specialists decreasing in rural areas because they cannot keep financially, like no tax income or no economical activities, and also clinically because 30 years ago, we have a big population even in a rural area. That means, so there are many patients like a heart attack or like a brain attack or even a very special disease. Still, the number of the patients are there. But recently, the people are going to a city area. So it was really difficult for specialists to keep their clinical work in a rural area. And as a result, in 2018, Ministry of Health decided to promote training general practitioners. Finally, the government decided we have to make general practitioners, even especially in rural areas. At the moment, it's the data is last year, still just only 1,000 GPs in Japan. This is a number of the doctors who are operating their own clinic. So in Japan, we have lots of specialty clinic. So, for example, in Japan, ophthalmologist is normally 13,000. But almost 9,000 ophthalmologists are working in their own clinic, not hospital. And like orthopedics surgeon, it's totally the number of the orthopedic surgeon to 22,000, but almost 8,000 orthopedic surgeons are operating their own clinic. So we have a lot of clinics, but it's not by the GPs. It's operating by the specialist. That is a special occasion, a special situation in Japan. It's different from the other countries. And as I said, so there are many hospitals in Japan. So the number of the hospitals per the people is the graphics above, and also the number of the hospital per the square kilometers. Internationally, Japan has lots of hospitals, and then the number of all beds. The Japan is a top country of the having a bed. So even in rural areas, there are many hospitals. This is the in rural hospitals in our areas. Looks like very big hospital. So still such kind of the big hospital located in a rural area in Japan. Like this, like this. These are there are these are all rural hospitals. And then present issues in rural medicine in Japan. So now super aged society. It's over 50% of the aged people are living in rural areas. And they all have multimorbidity. So if we would like to manage those kind of the patient by the specialist, we need a lot of kind of the specialist even in a rural area. That cannot happen. So, and also cannot afford to keep specialists and acute phase beds in a rural area. But fortunately, as I said, so Japan is a very, very small country, so not too bad access to the urban health facilities. So if we have more GPs or more general internal medicine doctors in the rural areas, as a purpose of the good quality health maintenance, maybe still we can keep good quality in the rural areas. So this is Japan, and Toyama City is here, and Toyama City is 2 hours and a half from Tokyo by bullet train, and 3 hours from Osaka area by the bullet train as well. Our prefecture has 300,000 people, and also one of the most rural areas, Hida area and Joetsu area, we have to manage. Yes. So this is Japan. Blue area is big city areas, and white area is rural areas. We have white areas, so we have to control such kind of rural medicine things. And also, disaster medicine. As you know, so Japan is a lot of volcanoes, and we have many earthquake, and typhoon is coming in the summer times, and snow and rain, and such a disaster is happening every years. So maybe some people in South Australia know we had a big earthquake in 1st of the January this year. Last year, I went to the place which had a big earthquake. That is very rural areas, and the tsunami was also coming. And lots of coastal area is rise up, and this is the last photo shows the people measured the height. So before the earthquake, this is under the sea. So 4 meters or 5 meters raised because of the earthquake. Such kind of the disaster is happening everywhere in Japan. So we have to learn like a disaster medicine even in rural areas. This earthquake happening here. So our, how can I say, medical student and interns and registrars have to not only their specialties, but also like a disaster medicine or community medicine in a rural area at the moment. So, but normally, the Toyama is a very beautiful place. In a winter time, in a mountain area, we have lots of snow, 15 meters high, deep snow in a mountain area. and also rural area. Still, there are many beautiful rice field things here. So if you are interested in our university, just watch our movies in home pages. Yes, thank you very much. So this is Toyama University and Toyama City and overview of the medical system in Japan. So if you are interested in, so we are very looking forward to seeing you here in Toyama. Thank you very much.
Thanks so much, Professor Takamura. Can I ask you a question? And there may be some other questions from people. Your area of research is in community-based medical education. What is the relevance of community-based medical education for the problems that you face in rural health care in Japan?
Yeah, so at the moment, the young generation, maybe the same, but young generations are really want to move to a urban area, city area, like Tokyo or Osaka to do their practice. So we have to we would like to keep young generations in Toyama Prefecture. So at the moment, I try to introduce a community-based clinical placement, which purpose is the student enjoy the rural life or enjoy their sharing the time with the local people, and also they would like I would like to make them understand the clinical skills they can learn clinical skills or knowledge or such kind of even in rural areas, such kind of the community-based medical education like PLCC program in Flinders University. Such kind of things I'm trying to do at the moment in Toyama.
Well, that's fascinating to see the differences between rural Australia and rural Japan, and the similarities, the economic disparity, the workforce disparity, in a way, the reputational disparity that's and the need for a different type of practitioner in rural areas to really leverage the strengths of a rural community and provide the very best care. Certainly, you have a lot in common with the Riverland Academy of Clinical Excellence that sees community-based medical education as the way of leveraging those strengths. That clinical skills are excellent, that knowledge is excellent, and that, as you said, enjoying the life of a rural community can be transformational for the next generation. Congratulations on the work you're doing. I look forward to further conversations about how our two health systems and our two education systems might be able to collaborate for the benefit of all our patients. Thank you all for being part of the Grand Round today and hearing the inspiring story from the western coast of Japan, on the Sea of Japan, and the amazing work that they do in quite difficult circumstances, as Aki was able to demonstrate. 5 meters, the land has risen in one day.
Yeah.
Let's hope that for both of us, our workforces can rise in the same proportion,
Yes.
but without the trauma of an earthquake to precipitate that. Perhaps it's an earthquake in systems that needs to occur in order to get that benefit. Thank you, everyone, and we look forward to seeing you at our next Grand Round. So,
thank you very much.